Good day, and it's great to be with all of you today virtually. I'm thrilled to have Schell with us. Sue is Vice President and Clinical Director for Behavioral Health at Children's Health, which is based in North Texas. She and her team were the co-third place winners in our Innovator Awards program this year for their amazing work in behavioral health care. So welcome, Sue. Great to have you with us.
Thank you. Thank you.
And I love your balloon.
The Children's Health balloon.
That's right. That's
go
right.
Anywhere in Texas.
That's right. Exactly. So first of all, why don't we begin at the beginning? Tell us a little bit about yourself briefly and your background and your role, your team, and your area at Children's Health, and then we'll talk about your innovation.
Sure. So as you said, I am Vice President and Clinical Director of Behavioral Health. I've been with Children's for almost 7 years, overseeing a number of behavioral health programs and representing behavioral health in our community. Children's Health is the children's hospital in North Texas. We see over 250,000 patients a year, or we did in 2020. We have 3 main locations: a hospital in Dallas, one in Plano, which is north of the city, and our children's house and acute care rehab facility. We have over 7,500 employees and over 50 specialty programs, and we've been around in the community for over 100 years now. So it's an honor to work for them, where our mission is to make life better for children in everything that we do.
That's wonderful. We're so glad to have you here with us today. So let's talk about the thing that has affected the entire world, the pandemic. At the beginning of the pandemic, you and your team had to work through some very challenging questions and issues around how to best care for children with special needs, including behavioral needs. You had 3 distinct populations that you needed to think about: general patients with various conditions, patients in recovery from substance abuse, and those with developmental disabilities. Tell us a little bit about what the considerations were that you had to work through in terms of those 3 different groups of patients.
Yeah, and they were pretty unique in their needs. So fortunately, Children's Health has always been innovative in technology, and we had a very robust virtual health program in place prior to the pandemic. So 2 of the programs already had virtual visits as a part of their patient offerings. For example, our teen recovery program works with adolescents with both mental health and substance use issues. And so it was not uncommon that a child would age out, they'd graduate, they'd be ready to go to college. And we quickly realized that having a virtual visit to stay in touch with that patient as they adjust to college life, supporting them to maintain their sobriety, was really critical. And so we had all the technology and systems in place prior to the pandemic. So when the pandemic started, and we literally, identified on Monday that we were all going to start working from home and be virtual, we had everything set up for that program on Tuesday.
And may I ask, about how many patients does that program involve?
Well, it's an intensive outpatient program, so patients are engaged in the program for 6 months to a year, or some even longer, for ongoing support. So it's that we have 2 therapists and a psychiatrist, and they probably have about 50 active patients at a time, and then those that are just in follow-up. And so the tricky part with that was, with substance abuse, it's critical to have frequent data checks on whether or not they're remaining sober, urinalysis and what have you. And so we just relied on mail order and started shipping drug tests, urinalysis tests to the patient's homes for the families to administer to the patient to keep a check on their sobriety. And interestingly, in the first part of the pandemic, when everybody was in 100% lockdown, we had very good attendance because the teens didn't have to go to soccer practice and all the different events that families have. They were available for treatment. And so we continued to have very good success rates in that program. We even used a different platform to continue our group therapy. It's a critical part to learn from others and develop coping skills and social skills, and continued our group therapy virtually as well for many, many months. And even today, I think overall at Children's, the virtual care has been so successful that we expect that about 30% of visits will continue to be done virtually, just for the ease of the patient.
Great. And the children with developmental disabilities, what were the issues you had to work through there?
Yeah, that was particularly challenging. Young children with developmental disabilities, autism, they're very sensitive to stimulation. And so you cannot get young children to wear masks. Although, once they're 3 or 4, that's part of our program now, is to teach them how to wear a mask and keep a mask on. But that program really had to shut down. And again, we were able to do a lot of work virtually. An interesting point with that was our neurologists, to connect with a child with autism is challenging, is difficult. That's part of the components of their illness. But to connect virtually is even more so. And one of our neurologists, Dr. Patricia Evans, has quite the musical talent, and had a ukulele. And she would pull out her ukulele and just talk in a singing voice while strumming chords, and identified that was really successful in reaching her patients. And so, necessity is the mother of invention, as they say.
I think that's the first instance of ukulele-based therapy.
Yeah, I think it might be, although music therapy has been around for a long time.
I just never heard of ukulele.
Well, it's small and portable. So what she did was we bought ukuleles for all of the residents in the program and gave them lessons on how to play a few chords so that they could do that as well. And now have a study underway about how that helps to connect with patients and how important that was in the virtual environment. So
that's absolutely wonderful.
Yeah, so it was really a lot of fun to see that work take off. All of our programs, surprisingly, had increased visits in 20 and 21 over 19. We continue with an upward trajectory. So amidst the challenges, we were able to continue to serve so many patients. And adapt. I think that's what it's all about, is being resilient and adapting quickly.
Okay, wonderful. Absolutely wonderful. Tell me about the school setting.
Yeah, so we've had a school medical program, virtual health program, and a school telebehavioral health program for a number of years. We started that back in 2017. And essentially what we do is we give the school an iPad, and the counselor refers a patient to us, and we outreach the family. They let the family know we're going to contact them, and they've given the information. And we do a telephonic intake. Our master's level clinician does with the family to explain that we're available to assist their child and talk about what the needs are. And get consent for treatment. And then the school counselor would arrange the appointment and call the child out of class for 30 minutes or so and give them the iPad and they connect with our therapists. This model was built off of a similar model that we have with medical homes, which we started many years ago, back around 2012, where we connect a behavioral health therapist with a pediatrician in the community for integrated care to make it easy for them to refer patients to behavioral health. And so in the school setting, it was the same program. It's just that it's a counselor making the referral instead of the pediatrician. And so that's been very successful. And the state of Texas in 2019 dedicated funding to the Texas Child Mental Health Consortium to expand that program across the state. So we now have funding for schools all over the North Texas area in a 9-county area, and other regions of the state have the same thing. The difficulty part with that, though, was that when kids weren't in school, the teachers and the counselors weren't identifying that they had needs. And so the referrals for that program, of course, dropped consistently over time. We still connected with kids that we could, and we still had some referrals coming in. But as you know, so many kids were sporadic in their class attendance, and you didn't have those teacher counselor chats in the hallway where things could be identified for referrals. So that became somewhat difficult. We then made the program available for direct consumer referrals, so that we put it on the school websites, and the parents could contact us directly so that we could reach their children. And that program continues to grow. As I said, with our state funding, we have more schools to add. And it's just such a tremendous need now for youth.
And what is the situation like now that children are back in school, but of course, many children were emotionally disrupted by the pandemic?
Yeah, it's very troubling. Some of my colleagues around the country have said that the mental health crisis pandemic was underway before COVID. It's just now getting the attention that it deserves, and it's going to be here long after COVID, because the impacts of this type of life disruption in learning disruption, the stress on families, when a caregiver loses a job or a loved one dies because of COVID, all that stress is in the household and impacts everyone in that household. And kids show that stress differently. So that's why we need to be educating so many people about behavioral health, not just the school counselors, but the teachers, the coaches, the church people, everybody, to be able to identify when a child needs to be referred and get some support.
Absolutely. So important. What you do is absolutely vital for our communities. So thank you for that. What have been the biggest challenges in all of this work in the last year-ish?
Well, I think initially the challenges were, we serve the whole community. So we have a lot of lower socioeconomic families, and the bandwidth for virtual care is not consistent across the community. The poor areas in our community have poor connection speeds, and that can make it difficult when you're doing a virtual visit and you want to see that child. Not just hear them and talk to the parent, but you want to get the visual and the connection. So not having good bandwidth and choppy connections. Back in the beginning, there were many times when the provider had to default to a telephone connection because the video just wasn't working. But, I think things are improving. There's been some focus on that. And families now are so much more comfortable with the virtual technology. So, we've had to rearrange workflows so that our front office team had the capacity to make those phone calls with the family and walk them through how to get it connected so they'd be ready for the visit. And that was difficult at first. but we persevered because, you know, the kids needed it. The families needed it more than ever.
Yeah.
So, yeah.
Absolutely, absolutely. And what would you say, tell us about the biggest lessons learned in all this so far? And they can be people, process, even technology, although it seems that technology worked well apart from the bandwidth issues. People, process, technology, anything. What have been the biggest lessons learned for you?
You know, I have to say, I love the team that I work with. I think a lot of people say that, but the way our whole organization stepped up, we have, you know, as I said, we had a pretty robust virtual health program before all this, but we had all hands on deck 24 hours a day with some of these team members. Because there were not all of our specialty programs had virtual health. And so they were setting up new departments, new users. We had people like my clinicians who had done virtual health previously. We had them involved in training other providers in how to use it. You know, providers, you know, not all of us, I'm included, we're not very techno savvy. So here you are in a pandemic, working at home with pets and children, and now we ask you to do this new thing on your computer. So it was helpful, I think, that we had some clinicians doing some of that training, kind of clinician to clinician, to get that started. And it was just really a heroic effort of all hands on deck to get that done and to continue. You know, our virtual program continues to grow as we reach outlying areas and, you know, our school program, for example, some of our outlying areas, there are no counselors around. So the connection to us virtually is amazing for those small communities.
In a school that doesn't have a counselor, how is the connection made to you? Is it through an administrator, like an assistant principal, or who facilitates that?
Well, there's somebody in the school that is identified as the person to make that connection. The school nurse, I mean, all schools have counselors. They're not necessarily on site all the time. So
or full time.
Exactly. So they have a number of campuses under their purview. So we work to train the people who are our liaison for each school, to get them up to speed and understand how it works. Their role is really in just connecting with the family, as they do all the time. If they have a concern about a student, they call the family. Only this time they call them and they give them the solution of, we're connected with Children's Health and we can offer you virtual behavioral health therapy through this program at no cost. So that's the wonderful part about the state funding. And we have lots of philanthropic support as well that lets us provide this at no cost to the families or the schools. So we're really focused on increasing our access points and as I said, getting kids with needs identified early on in the process. If we can identify with a school counselor or a pediatrician a kiddo who seems a little bit anxious, or their grades are dropping and they need to, we need to figure out what's going on. If we can identify that in real time and intervene, you know, that kid isn't gonna exacerbate and ultimately become so depressed that they start to harm themselves or end up in the ED because they're suicidal. That's the whole goal, is early identification, prevention, and intervention in real time.
It's terrific. What would you say to those who might follow in your footsteps and try to establish something similar? Key pieces of advice for things that they should do. And obviously, everyone is coming out of a different background and a different situation. They have a slightly different population. They have different resources internally. But very, very broadly, what things should people think about as they do this?
I think, nobody could do this alone. It takes a lot of community partners. We're very engaged in the community across the state and nationally. There are a number of programs across the country. Children's Hospital Association offers a number of learning opportunities, and they have a specific group on behavioral health where we all share our best practices. I've learned lots from other pediatric hospital systems, but I think the first step is not to try to do it all yourself, to reach out in your community to find good partners, because it's all about increasing the access points. Our hospitals, we're in a large city, and people can't always get to our hospitals for care. So we have to go to them. And that's kind of where all of this started from, is recognizing that we don't need to wait for patients to come to us when they're really sick. We need to go to them when they're just starting to have issues and educate. So much behavioral health, mental health, substance use has been, behind the black curtain and had so much stigma to it that we don't talk about it. And it's so important to talk about and to say, yeah, my child, I think, is really struggling. I want him to talk with somebody. And so that's kind of part of our mantra, if you will, is that we want to make behavioral health care a part of everyday health care. And with these programs and with virtual technology and the access we have in the community, the education we're providing, we're really seeing progress in that area, that we want people to call and ask questions so that we can get them the help they need.
That's wonderful. And let me just ask one follow-up. What would you like to share for healthcare IT leaders that they should know and think and do, and also clinical directors of programs, the two different groups?
Well, I think you have to work closely together. You can't have one without the other. We have our colleagues in IT that we just are in awe of, what they know how to do, that we don't know what to do. And they're in awe of us too, when they hear us talk about patients that we've helped or families that we've reached. So I think you have to have a strong team of collaboration. You rely on our IT people to keep us up to date with the latest technology, because we don't know what's going on. And yet we also have ideas about how we can better reach patients. We use texting and voicemail and all kinds of things in addition to a virtual connection to reach people in real time. And knowing that that's where people are. I'm on the older end of the continuum now, but young families, they go to the internet to find their care and to get recommendations. And so we need to be savvy to that and know that that's how they want to be connected with. Giving them questionnaires on our websites and connecting electronically before a visit helps to facilitate that visit. And, just always being open and asking. We have a large family access network where we get input from our families on what they want, really focused on that consumer experience so that we are meeting our families' needs in the way that they want to be communicated with.
Yeah, and I think you're absolutely right. What we're hearing that completely validates what you just said is you have youngish families, relatively young parents, in many cases, even in their late 20s sometimes, with younger children.
Right.
Those are, dare I say it, younger people than us, and they've grown up online, right?
Exactly.
Themselves. And so they want to interact in the most contemporary way possible, right? They're not going to wait for a typed mailed letter, right? They need to interact on their terms. So I think that's absolutely wonderful. this is so fabulous. Any last closing thoughts?
I just thank you all very much for the recognition of the award. We're proud of our work. I'm so proud of my teams that really went above and beyond so quickly during the pandemic and continue to do so. And excited to share it. So thank you so much for the recognition and the honor.
Absolutely. You're so very welcome, Sue, and your whole team. What you're doing exemplifies what we're all about. Innovation is in our name, and we want for everyone across the US healthcare system to benefit from what others are doing. And any organizations where there are teams that are leaders showing leadership, as you and your team have done, we just want to spread that so that people can learn from one another. That's
We appreciate it. I look forward to hearing from others in the conference.
Absolutely, absolutely. Well, Sue, thank you so much. It's been a pleasure and an honor. And again, congratulations. And I want to wish you the absolute best wishes as you and your team go forward into the future.
Thank you very much, Mark. It's nice to meet you. And again, much appreciation for the recognition.
Absolutely. Thank you. So thank you to all of you in our audience. And this concludes this session in our conference.